I'm Andrea Quintanar.
And I'm Annika, we're the marketing interns. Today we're going to be doing a foam sclerotherapy procedure and our foam barista.
Hi, I'm Maria. I'm a vein care specialist here and the foam barista.
Maria's a very experienced foam barista. Dr. Chris Pittman here, unabashed foamaholic. This young lady had been treated elsewhere and had not really gotten where she needed to go. She had some residual varicose veins and also a magenta colored ankle down here. We've already treated this side. I think I'm just going to show you what's going on. So she got a good looking leg. She's improved a lot just since our last treatment, but all in this area was very blue-purple spider veins. A few tiny ones are left over that we'll get later, but I want to demonstrate for everybody, and all the vein docs will get this, that she just has a bunch of very large, dilated varicose veins really hiding under the skin. So if we come down in here, we can see she's got a little edema here surrounding your vein, which is normal post-treatment, but you would not imagine that she has this many varicose veins. Now they're all closed because we already foamed this area. Any vein that is a curlicue is an abnormal vein. Normal veins don't do this. They don't do that on the skin, and they don't do that on an ultrasound. They're always abnormal if they're kind of a corkscrew situation. And so these are all abnormal, and they've been previously treated, and because we're bringing her back to schoolgirl legs, but she's still in the caterpillar stage right now. So we're over here on the other leg, and she doesn't have huge tributaries, but they're not doing her any good. So on the ultrasound here, I'm going to show this tributary vein lengthwise. I've been talking and probably scaring the crap out of her, so this vein's a little smaller because there's little smooth muscles in our veins that can make them kind of collapse a little bit. So foam barista Maria's given me some foam. I've identified the vein in longitudinal dimension, little pinch there. There was a little bit of a delayed warning. I pinched her and then I told her pinch. Sorry about that. And you want to look over there, okay? And you're going to see the needle coming into the vein there. Again, this is routine. I think most of the vein docs out there, I'm actually not quite in there. Now I'm in there. Hang on. There we go. So we're a little in, we're a little out, but we got that tributary vein. You can see the foam in the vein right there. I'm going to follow this through. There's a little bit left over here. So we're going to get that. I'm going to give this back to Maria. There we go. And we're going to go down on this tributary a few more centimeters and get the residual here. There we go. So we can see a little bit of foam in the superior aspect of that vein in longitudinal dimension. The black pipe. This is 4th grade stuff. The black pipe is a vein, and when we inject the foam, it's going to turn into a white line because it spasms or collapses when we inject the medication. And these venous tributaries aren't much bigger than my vein here, than the size of this vein. And of course, it's going to be challenging, right? Because we're doing a video. So there we go, we're in, we're injecting, and you can see the black pipe turns into a white line. This vein is, no more than about 3 to 4 millimeters. I'm injecting. You can inject with impunity, volume-wise. above the knee. You're not going to run into any problems below the knee. You want to be a little careful. You doing okay up there? That probably burned a little bit, didn't it? She's going, yeah. And it burns because we're dilating the vein a little bit, especially when we treated them before. This is number 2, number 1, number 2
Number
on
two.
there. Yeah,
Mhm.
yeah, exactly. Okay, so once again, you're not going to see much here. My ultrasound tech was in here earlier. This is a serving suggestion. So she marked an area that she wants to bring my attention to. She documented various things that we put on the ultrasound report. And this is just an area where I'm going to go. But you're going to want to focus in on the ultrasound because that's where we're really going to see the target veins that we're going for here. And again, these are not gigantic, but they're big enough to be a problem. So I'm going to mag up on that a little bit. And we want to put those not on the gel up there. We want to put those up there. Okay, very good. So once again, we're going long, pinch. Most practitioners do axial, but obviously I think long is better. The truth is it's best to be good at both long and axial. And of course I'm having a little bit of a struggle there. Let's see. Some of these are actually closed. Yup. Okay, there we go. A little bit partial. Closed from last time. Let's come down here. Yup. Those are closed. Let's keep coming. Coming down the leg. Alright, so these you can see they're going winky winky, clearly open. So, back here. Annika, how you doing?
Doing great.
Alright. Okay. So we see your vein on the ultrasound there, pinch. Really, there we go. Pick some tough ones today. One is search and destroy, making sure all these ones are closed. There's something we need to get right there. So if you're videoing, you didn't have a lot of tributary veins on this leg. It's not quite as bad as the other side. There's some winkers right there at what we call about zone 8. We're doing a lay of the leg or a lay of the land here. Once again, you can see the complexity of her veins down here in her ankle. You would never suspect this looking at, her skin, but this isn't good. I'm going to get this. A lot of practice. You can see how complicated that kind of mess is right there. There's what we call perforating vein there. I'm going to go ahead and inject this. Perforating veins, a lot of doctors are intimidated to inject. And I'm near the perforating vein, but I'll show you what we're going to do. Pinch. This will help her with symptoms and help prevent a magenta ankle on this side in the future. So there we go. I'm injecting. You can see foam in there. Gently injecting. I'm not concerned about a little foam getting into that perforator. It's just no big deal. There we go. Okay. And then when I was serving up here, you can see how far up this foam got. It I do some of that's intramuscular. It's almost a gastroc vein in this area. It's not. It's just deep too. So it's very complicated. She's had this procedure in the past, and it's led to some unusual post-op anatomy. I'm sure she doesn't want to be unusual post-op anatomy, but we're getting rid of it all here. Yep, let me get rid of that up there. There we go. So there's going to be medical benefits that accrue, and certainly cosmetic by getting rid of this stuff. Pinch, pinch. I'm going to inject. I'm going to look around a little bit. See, I see yet another area. She's a bit like, she's a bit like Swiss cheese here. See that? Swiss cheese right there. Hang on, there's a little foam kind of trickling in there now. There we go. Okay. Pinch, pinch, pinch. So just because we see foam swirling around in that vein does not mean we put in enough. In fact, I know we haven't put in enough. You don't want to see swirling blood. If you can see swirling blood, you have not put enough in there. Are you feeling okay up there? You okay?
Yeah,
All right.
that one kind of.
Okay. It's gone away?
Yeah, it is.
Okay.
No, no.
Okay, I think that's going to be it. Yep.